All right. Thank you all for coming to our Visiting Scientist lecture series. There's some of you who are virtual, some of you in person here. It gives me great pleasure to introduce today Dr. Shannon Juengst. She's a clinical investigator at Tier Memorial Hermann, a certified rehabilitation counselor, and an adjunct associate professor in the Department of PM&R at UT Health Sciences Center in Houston and at the University of Texas Southwestern Medical Center. Her work focuses on developing evidence-based interventions and measurement tools for behavioral and emotional outcomes after traumatic brain injury, or TBI, applying innovative telehealth and mHealth or mobile health methods and technology to improve long-term self-management, and investigating biopsychosocial relationships among individuals with TBI and their care partners. Dr. Juengst is recognized as a leader in the field, being awarded the Deborah L. Wilkerson Early Career Research Award in 2020 and the Joshua B. Cantor Award in 2021 by the American Congress of Rehabilitation Medicine, ACRM, a leading professional organization in the field of rehabilitation. She has published over 100 peer-reviewed manuscripts, presented over 120 scientific lectures or posters, mentored over 50 students, residents, postdoctoral fellows, and junior faculty, and received funding from NIDLR, NIH, and numerous foundations. On a personal note, Dr. Juengst is not only a brilliant scientist, but she gives very generously her time, expertise, and wisdom in collaborative work. And it's been a great pleasure learning from her these past couple of years through our association with the model systems. So her talk today is entitled Multidimensional Health Perceptions, Conceptualization, Measurement, and Implementation. And with that, I'm going to pass it over to Dr. Juengst.
Thank you. I'm actually really excited to be presenting to this group. I've worked quite a bit with the brain injury investigators at Moss and similarly learned quite a bit from them. So as Dr. Venkatesan indicated, I'll be presenting today on the Multidimensional Health Perceptions Questionnaire, in particular, a measure that I've developed, and just kind of more broadly, talking a little bit about just measuring health perceptions in diverse populations generally. I have two kind of main areas of research focus. One is intervention and behavioral health intervention, and the other really is more psychometrics. And so this is more the latter. I'll be talking a lot about instrumentation and psychometrics of this measure, but it really was born out of the need to improve our behavioral health interventions. So it's a nice mix of both. So related to that, one of the big shifts over the last few decades in care and healthcare is towards person-centered and culturally competent or culturally humble care. And what this really means is that we look at a person not as a disease or a condition to be treated, but rather as a holistic person. And I think as there's increasing awareness of the effects of personal beliefs and cultural values on healthcare outcomes and healthcare engagement, this has become a really important area of focus. So what does it mean to engage in person-centered and culturally competent care? It means we really take into account a person and their family's belief system, their preferences, their values, personal and cultural values, the resources they have available and their abilities. Also expanding beyond that, more recent models of kind of culturally humble care really push for the need to include consideration of a person's interpersonal interactions, both with their healthcare providers and just out in the world, and the effect that that has on their belief systems and on their systemic experiences. So, specifically experiences of microaggressions, stigma, and discrimination in healthcare settings. So it's really pushing us to move beyond biomedical approach to a biopsychosocial approach, or perhaps even more broadly, a biopsycho-sociocultural approach, if anyone can actually pronounce that. And this really means in practice that providers have to have gather even more information to practice in this way from the people that they're working with. And on the flip side, tailor their communication approaches and the way that they deliver healthcare recommendations and information accordingly. So why is that challenging? So it really requires that you consider a whole person in a larger social environment. So that's a lot more information that needs to be gathered in an increasingly short amount of time. So a lot of patient-provider interactions are very time limited. There may not be good tools available for conducting kind of assessment of these broader factors. And, so we need kind of to be efficient in practice, but we also have to avoid falling into the trap of cultural stereotypes. So it's really not enough to, see somebody who is, for example, Hispanic and just make an assumption that they are going to be more family-oriented, for example, or more have stronger religious or spiritual beliefs. So we really need to not fall into those traps. We know that health beliefs are foundational to living healthy lifestyles and to health behaviors. Beliefs are foundational to behavior in general, but it's rare that our behavioral interventions and behavioral health interventions are modified and adapted to account for those individual beliefs. We know that these beliefs affect how people engage in healthcare, if they adhere or comply with treatment recommendations, if they actually have uptake, which, from a behavioral health perspective means, are they actually, taking in what you're trying to teach? Are they going to take whatever the intervention or education is and go translate that into actual behavior change? And then we know these beliefs affect healthcare clinical outcomes. And I'm not going to go into all of the background literature on that, but there is quite a bit out there. And there are a lot of models, the predominant one being the health belief model, that's sort of foundational to this. But we know that health beliefs are more complex than that. They're very intertwined with other values, with experiences, and with health literacy. So this is sort of what led to the development of this measure, is that there's this critical need to really understand in more detail the link between health beliefs and health outcomes, and understand it in a way that provides very clear guidance for how we can adapt our interventions and our intervention approaches to provide more patient and family-centered and culturally humble care. So that led to the development of the MHPQ, the Multidimensional Health Perceptions Questionnaire. And really, we knew that there were existing health belief measures. There are some pretty good measures out there, but they tend to either narrowly focus on a particular dimension of health beliefs. So there are measures for internal locus of control. There are measures for God-related health beliefs. There are measures for external locus of control and fatalism. But they tend to be focused. So if you want to have a broader conception of a person's belief system, you'd have to give a large battery of measures to capture that. They're often limited to specific conditions. So health beliefs about diabetes, for example, health beliefs about brain injury. I don't know that there's any of those. There are some for stroke. But then they're condition specific. And we know, particularly working with people with more chronic conditions, that it's very rare a person's health centers around a single condition, that it's more complex than that. And then the measures are often not adapted for cultural and linguistic minorities in the United States. And so to capture the complexity of health perceptions, and with the end goal of really trying to improve health disparities and hopefully reduce some of the biases against cultural and linguistic minorities, we developed the MHPQ for both English and Spanish speakers in the US. And that's not to say that Spanish speakers are the only linguistic minority, but they are one of the larger linguistic minorities in the United States. And then I started this work in Dallas, and I am now in Houston. So in Texas, it's of particular importance to us to be able to serve primarily Spanish speakers. So I'm going to first go over the development and content validity of the measure. This paper was actually just came out in print 4 days ago, so this is very timely. The QR code will take you to the link if you're interested, and it is open access. Throughout, I am going to talk a little bit too about the process that we took to develop this measure using a patient-centered outcomes approach with a particular lens towards adapting this for minoritized groups. So how do we do this? We first developed the item base for the MHPQ in English and Spanish simultaneously via kind of parallel content expert panel review and end user feedback. Some of the patient-centered techniques we used were expert panels, focus groups, cognitive interviews, and then a pretty rigorous translation and language validation process that I'll describe. The other thing that we were focusing on, in addition to English and Spanish language, we wanted to make sure that this was accessible for people with low literacy. So
Ryan?
pretty substantial problem.
Hi. Are you home?
Hi, Roberta, could you please go on mute?
What's happening? Are you home by yourself?
Roberta, mute.
No, my parents are home.
Okay.
Roberta Brooks, can you please mute yourself?
When you say you might not be around for a while,
Yeah.
what's
Sorry,
happening?
Shannon, one
Feel-
second.
Do we have a host that can kick somebody out?
Overwhelmed and
I'm trying to see how we kick people out. Oops, I should do that.
and having suicidal thoughts.
Where?
It doesn't look like you.
Do you feel you need to be somewhere so you can be safe?
Oh, jeez. We
Hi,
should not be hearing
Roberta?
this. Roberta!
Yeah, I think that's. The MRRI came back and they said that it came back.
She can't hear us.
Tell everyone to log, go back to the link. Putting out way, but.
The same link, but she'll still be on it though, right?
I didn't realize the MRI was this week. I was thinking it was later. Am I confused?
No, I had it done on Saturday.
Sorry,
Okay.
Shannon, one second.
And
Audio.
so
no.
there's still more questions than answers.
Isn't there a way to mute all of the participants?
Yeah, I didn't really.
Yeah, I don't think I have host control. That's the problem.
I was hoping something that came up.
Can anybody call Anthony?
Now you
And nothing.
now you have control.
I have never muted someone, so I don't know.
And nothing came up.
It's remote control.
I think you were successful.
It looked like that worked.
Be gone. Or-
That was awful.
All right, Shannon.
Did Anthony just do that?
It's all right. After a couple of years of all the Zoom, we've experienced it all, right?
Yeah, yeah. Okay. All right.
Fine. Gave me a water break. Okay. So I don't know.
That's-
Okay, I'll just go on from here. So we used patient-centered outcomes approaches. That's the gist of it. So the first thing we really did was to develop a conceptual model to guide the development of the items, the questions in the measure. And these are kind of the broad areas that we really focused on. And we came up with these through a combination of lit review. What does the literature say about health beliefs? We also looked at a large number of measures out there on these beliefs, and all of those are listed in the paper. But then we also, as a team, really wanted to expand. We started on the basis of the health belief model to guide some of these, but then adding concepts from social cognitive theory and adding concepts from ecological systems theory to start to broaden this idea of beliefs beyond just to perceptions. That's why we use the term perceptions, beyond just beliefs about things like the causes and consequences of injury and internal locus of control, but to really include perceptions of stigma, perceptions of anticipated discrimination, trust in healthcare providers. Over the last couple of years, I think it's been very evident that people trust different sources for their healthcare information, and we need to be really aware of that in tailoring how we provide that information. So we trust in social networks was one of the things we were looking at too. And so that really guided how we came up with the items. This is our health perceptions model. That is our conceptual model for the measure. I would not call this a theoretical model because it really is very specific to this measure. And the idea basically being that, you know, there are individual factors that we're not measuring. So we're not actually measuring a person's religious and spiritual beliefs themselves. We were really focused on their beliefs about the role of religion and spirituality in health. But we know that those beliefs will interact, those broader beliefs might interact with some of these factors as well. Their level of acculturation, their cultural values, and a wide variety of social determinants of health are going to be really important in this and likely interact with these health perceptions that they have. The kind of center of the model is just all of the components that we believed would go into a person's broader health perceptions. And we then, you know, indicate here that all of this has an impact on how much they engage in healthcare or how they engage in healthcare, treatment adherence and uptake, and health outcomes. So based off of all of that, we developed an item bank, and we really used items from other measures. We looked at concepts that there weren't any items for and kind of proposed some different various ways of wording questions. We originally had 104 items. And some of them, there might have been 2 or 3 that sort of asked the same question. And we were really trying to understand which wording was best. We had our expert panel rate the relevance of each item and use that to develop a content validity index. So the relevance was very high. It was 4.2 out of 5, average across all 104 items, and a content validity index of 98.1, which is excellent. We then conducted cognitive interviews, which are one-on-one interviews with 4 English speakers and 5 primarily Spanish speakers. So these are individuals who are bilingual, but who really spoke only Spanish. 25% of them were women. They ranged in age from 26 to 91. So we had a really nice age representation. Education ranged from 6th grade to bachelor's degree. So we also had a pretty nice spread across education level. And these cognitive interviews really probed, we had about 10 items that we, on the measure that we very specifically had questions about, asking them, you know, if there's 3 different ways of wording it, which one made more sense, if they meant different things to the person, because we really wanted to make sure that what we were trying to capture is what they were responding to. And then we had some open-ended questions about health beliefs, and I'll share just a couple of themes that emerged from their responses to those questions. The first was that all of them, and this was universal, which was really, I don't know, surprising, but it's very nice to get that in research. Our participants really indicated that there are multiple and often coexisting factors that influence health and illness. So we didn't have anyone who was, you know, said, your health is all up to you. It's all controlled by your health behaviors. But all of them indicated that it is to some degree. On the, you know, on kind of another spoke of the wheel of our model, we had people who indicated that spirituality, and that included not just religious beliefs, but broader spiritual beliefs, genetics, family and social support. These are all factors that play into health. So it was a nice support for our multidimensional conception of health perceptions, that there isn't just kind of one domain that affects health, but that it's multidimensional. They also, and this was something that we didn't necessarily expect, really suggested that there were these different factors would be different depending on the illness or depending on the condition. So just as one example, something like diabetes might be more driven by self-behaviors, but something like cancer, they might feel was more driven by more factors outside of their control, external factors. And that changing their health or managing it, if it was more reliant on self-behaviors, required more behavior change. Whereas for managing something that perhaps they couldn't change, but had to live with, maybe some of the more external factors or the more spiritual beliefs were important for how they perceived their overall health. Okay, so I'm going to take a little bit of a tangent here to talk just briefly about the language validation process we used, because I think this is really important and nicely illustrates the importance of these kinds of approaches, particularly for cultural and linguistic minority groups. So this is just an outline of the language validation process. This one is specific to English and Spanish. And you'll see that there are several steps. The first, and I think all of these steps, we do some of them, but a lot of them are not very commonly done in our health-related measures. So the first step is to test literacy level in English. And the recommendation is that health information measures should be 8th grade or lower education, 8th grade or lower reading level. It's important to test that literacy level first in English before translating to any other language, because often the literacy level when you translate actually goes up. And that's because English has how many words for, how many synonyms for a single word. The last slide was kind of a nod to that. Whereas Spanish has a lot fewer words. And so there might be one word in Spanish that covers multiple concepts. And so if you have kind of this high level of specificity in English, it often, when you translate it, kind of ups the literacy level, because you need a lot more words and a lot longer sentences to convey the same concept. So if your literacy level in English is too high, the first thing is to modify the English. And fortunately, when we first developed this, we targeted a low reading level for English. So that was right out of the gate, we did that. I can tell you as one example, a very commonly used measure, the PHQ-9 for assessing depression, depending on the readability statistic you use, is a 12th or 13th grade reading level. So this is a really big problem, and this is health literacy we know is incredibly important. So that's an important step. Then we translated the English to Spanish. We actually translated and then back translated to confirm the accuracy of the translation. And that's important. It needs to be accurate. And that's usually where translation stops. So if you send a measure to a professional translation service, that's the end. They confirm the accuracy. What they don't do is test the literacy level again. And so then once we confirm the accuracy, we tested the literacy level in Spanish, made adaptations as necessary to make sure that that was also low literacy. Then we conducted the cognitive interviews. And the importance of this is to ensure conceptual and cultural equivalence. And I'll give you a really good example of an accurate translation that does not convey conceptual and cultural equivalence in a minute. But this is where the cognitive interviews are very important. The other thing we can do here is that a lot of readability statistics rely on algorithms like number of words in a sentence and number of multisyllabic words and how many syllables are in the words. And if that ups the reading level. But there are some words that might have 4 or 5 syllables that are still very common, are so common that they're understood by even someone with, a 2nd or 3rd grade education. And so the cognitive interviews let you probe those things, where if you have kind of a big word or a long sentence, you can specifically ask and evaluate how well that's understood, if it really is kind of a high literacy level or not. And so we did that with a number of items. And then based on all of that, you're going to modify again to make sure you have conceptual and cultural equivalence. And the end result is a low literacy, conceptually equivalent English and Spanish version of your measure. And that's where we ended up. So just to illustrate briefly the problem with translation, and I should say translation alone in the absence of validation. You can have accuracy problems, that always is possible. You can have literacy level differences, which I mentioned. Often when translated from English to another language, the literacy level goes up. And then this problem of lack of cultural equivalence. And the consequences of this are pretty significant, because it means we're not communicating accurately. It can result in poor compliance and poor understanding of healthcare recommendations. And it can mean incorrect assessment on our side. If we're asking a question and we think we're asking question A and they're answering question B, and we're basing treatment decisions on their answer, that can be a pretty significant consequence. So here's my example. I borrowed this from a colleague of mine who's a medical anthropologist who does this language validation work. This is actually the 2nd measure she and I have worked on together. But she shared this example from a different study that she was working on in doing language validation. So the item that they were translating was, I like to do things with my friends. And they translated it as such. And this is an accurate translation. I don't know if there are any Spanish speakers here who have already got the joke, but this is an accurate translation. And when they went to do the conceptual cultural equivalence in cognitive interviewing, their Spanish speakers would chuckle at this, because this has a very different connotation than in Spanish than it does in English. The equivalent would be more of I like to do things with my friends, which is not the question that they were asking clearly. So, I like this example because it's funny, but you could see how this could happen with more, with health-related questions, and how this could, have consequences. So, thank you for taking that brief digression. We're going to go back to the MHPQ. So our end result is that we had, in the beta version of the measure that we developed, we had 91 items rated on a 1 to 5 point agreement scale. So it's strongly disagree to strongly agree. Items and instructions had a modified small reading level of 6th grade in English and 8th grade in Spanish, though we did confirm that some of the specific multisyllabic words driving that 8th grade level were actually very common and understood at a lower level. So we feel pretty confident that the actual reading level of the Spanish is a bit lower than that, but 8th grade is still, under the recommendation. And I think that this whole process really demonstrates the importance of, one, systemic cultural adaptation and language validation, and really involving our end users in this process, and hopefully also the importance of low literacy measures. So then the next step was our psychometric work. And this is, for those who have more of a background in psychometrics, factor structure just basically of a measure basically just means what are its subscales. So we went into this knowing that while the broader measure was health perceptions, we designed it to be multidimensional, which means we expected it to have different subscales or domains. And what establishing the factor structure does is it tells us which items measure which of those domains. Once you have that structure, you look within each of those domains, and you want to evaluate the internal consistency reliabilities, which essentially means do all of the items in that domain measure the same latent construct. So are they highly correlated with each other? And so this is what we did. And so to do so, we administered the MHPQ as an anonymous survey. We used REDCap to English and Spanish speakers across the United States, although most of them were in like Dallas area. We used the UT Southwestern Community Research Registry, which is made up of all patients who come through UT Southwestern's hospitals, clinics. So it's a wide range of people. It does include, and you'll see this in our demographics of the sample, all of the faculty and staff also who work there, who tend to get their healthcare there. So that ended up being problematic in terms of our education distribution, but it was, this was an unfunded project. So, you know, you work with what you've got. We also had, you know, with my interest in TBI, I wanted to make sure that I included individuals with TBI in this, even though it was intended to be a general population sample. So we had an acquired brain injury research registry of survivors and their care partners. We sent this out to them as well. And then we also posted on social media and used snowball recruiting. This is a map of our survey responses. The blue are English responders, the orange are Spanish responders, and the numbers are how many from that region. So you'll see that, you know, obviously kind of Dallas area was our largest by far, but we do have people from all around the country. There was one person who is a US citizen but was in Colombia. That's why there's that one from Colombia. So that was that. The other measures we captured were just some basic demographics. And then we had a checklist of, let me take that back. We had an open-ended question where we asked people other health conditions that they had, and they could type them in, and then we categorized those. And I'll share that in a moment. But we wanted to really make sure that we didn't have a sample of people who had no health conditions, who are all very healthy, because they likely have very different health beliefs. Again, we know our beliefs are driven by our experiences. So we did an exploratory factor analysis. I've put a bunch of the, again, for the more psychometrically, statistically oriented, you can look at the all the numbers in the test, but essentially all of these approaches were just to ensure that our approach was appropriate, that the models all fit well. We calculated our Cronbach's alphas, which is the measure of internal consistency, and the minimum is 0.7. You want to be above 0.7 to be at least acceptable. So that was the goal. Our results, we had 357 people who completed the survey, which is a good number for factor analysis. 26 were Spanish and 331 were English. And of the people who clicked on the survey at all, it was about a 60% response rate. These are our participant characteristics. We had a preponderance of women. Again, not terribly surprising in research. Women tend to be more likely to participate. The lines got a little bit off, but that 246 is our white, European, or Caucasian, so that should be up a line. So it was still majority white. We did have representation of other racial groups, although not representative necessarily. It was about 24% Hispanic, which is actually pretty close to the national. I think the last US Census data indicated 28 or 29% Hispanic across the US. We have language fluency there. You'll see education-wise, we had a very highly educated sample, and that's probably the biggest limitation of this sample for this measure. And then our age range was pretty good. So this is just a frequency table of our health conditions. All I wanted to demonstrate here is that we had people with lots of different health conditions. That far left one is hypertension and high blood pressure, so over 60 people. A little further down, just over 20 people had TBI. We had about 5 or 6 people with stroke. So we had a lot of different health conditions represented. So our results, the short story of this is that our data were appropriate for factor analysis. We found a multidimensional structure with 7 domains or 7 subscales. They all had good internal consistency reliabilities, and the final measure ended up with 65 items. So another goal and benefit of factor analysis is you can reduce the items down to those that really are sort of the best and strongest for measuring your constructs. So it's 65 items, all measured on the 1.5 agreement scale. That's across 7 different domains, so it's not a lot of items per domain, and it takes about 10 minutes to complete. So even though it's 65 items, it's pretty quick. These are our subscales. With factor analysis, you just get your batch of items and you have to give it a name, like what is it that you think this is measuring? So these are our names, for better or worse. The first one, which really was, it kind of surprised me that it jumped out as our strongest factor that explained the largest overall variance in the broader idea of health perceptions, was our anticipated discrimination and judgment. The judgment part includes some of the questions we had tied to stigma, and the discrimination. We had a partway down, we had kind of a caveat, like a extra instructions that said, because of your race, gender, and there was a whole list of various things. Do you think that you'll be treated differently or be treated less well? And then there was a handful of questions. Just of note that these are perceptions, not experiences. We are not measuring if they have experienced discrimination and judgment. We're measuring if they believe that they will when they see a provider. So I think a lot of these domains would pair really nicely with measures of experience. It would be really interesting to look at that, to understand that. Our second factor was spiritual health beliefs. Third was social and emotional well-being beliefs. This is both how your health affects your social and emotional well-being and how your social and emotional environment affects your health. Confidence and trust in healthcare providers and medicine. Health self-efficacy, which is probably most similar to concepts of internal locus of control. Trust in social health advice. And so that's social media, family and friends as your main source and trust for health advice. And then health literacy. And again, this is a person's perception of their ability to communicate and to understand communication from their health provider. It's not an objective measure of health literacy. We looked at how the scales correlated with each other. The factor analysis we selected was one that assumed they would correlate with each other because we thought they would. And this is just kind of showing that our anticipated discrimination, confidence and trust in health and medicine, health self-efficacy, and health literacy all kind of correlate together. They cluster together a bit, whereas the others are a bit more independent. These were, we just kind of ran some differences in our scales. So the scores are an average 1 to 5 measure across all the items on that subscale. We just were kind of exploring some of the differences by some of these demographics, and the yellow circles are just ones that kind of descriptively jumped out. You'll see that our indigenous populations and native populations had the highest anticipated discrimination, and also were among the lower health literacy. There was some difference for our Spanish speakers and for our very small number of people with less than high school education. So we know that there are some demographic correlates potentially for these different health beliefs. So kind of our conclusions and future directions, we need to validate the MHPQ in a more representative sample with individuals with lower education and lower health literacy. If you're ever using a measure, it's always important to validate it in the specific population you're working with if it hasn't been. So this is, we intentionally did it in the general population to be a nice kind of foundational good measure that you could then take to a specific population and make sure that it was valid in that population as well. So for me, that next step is validating it in brain injury. And then the end goal was that we could take these 7 domains scores and develop profiles. So using profile analysis, kind of clusters or profiles of people who had particular patterns of health beliefs, and that based on those, we could develop some recommendations for providers to, kind of give them recommendations for how to tailor their communication approaches, how to, if a person has low trust in health and medicine, in healthcare providers and medicine, then maybe it's important to take more time to establish that trust, to understand that if you just treat them and give them a recommendation and send them out the door, they're probably not going to follow it because you're not, the source that they trust the most. So how can we shift things around to deliver the information in a way that's more going to be more effective and that's more value consistent? So just as a quick little teaser, we don't want to actually develop these profiles in our development sample for a number of reasons, but we wanted to see if there actually would be profiles and to kind of test that we could do this. So we ran a latent profile analysis in our 357 people. We established a 3 profile solution, so 3 kind of clusters of or classes of health perceptions, beliefs. And these were the different profiles. You'll see one of the profiles had about 43% of our sample. Some of the characteristics that identified the people in that profile is that most of them were identified as white, and most had this was the group that had the most with a graduate degree. Our third profile had about 50% of our sample, and actually in terms of demographics was just kind of balanced across the board. It didn't have the most or least of any particular group. And our second profile, which only had 7% of the sample, you would call this a minority class, just because it is a small group, but often those small groups are really important because they're the people that aren't, we tend to treat to the majority. And so if you've got a kind of minority class or group that's a little bit different than the majority, they're the ones that you probably most likely have to do the most adaptation. And you'll notice that this group included across the board the highest percentage across multiple minoritized groups: ethnic, racial, gender, and probably income. If you look at the most homemakers, most VOTEC and associate's degree. So, that's kind of important. And this is just a snapshot. Each color is one of those different profiles, and the different chunks are different subscales where you can see the pattern in health perceptions across the different profiles. So, trust and social health advice was pretty consistent across all of them. So that was not one that varied. But looking at anticipated discrimination and health literacy, you'll see that the 3 profiles really differentiated sharply. And there's some other differences in between. So it really supports that there are these kind of distinct patterns of health perceptions. So these are our kind of the overarching conclusions. One is that we really need to adapt our healthcare delivery based on a thorough assessment of health perceptions. And hopefully that will improve engagement and outcomes and avert preventable conditions. The MHPQ is kind of a start. Early evidence is really promising, but we need to do a little bit more work to kind of firm it up and validate it. And then really we have to start to develop those profiles and work to come up with recommendations to providers that will, based on those profiles, that could help guide their practice. But essentially this is important. We need to find ways to better include values and beliefs if we, one, want to engage in patient and person-centered, culturally humble care, but also if ultimately we want people to change their health behaviors, we need to start recognizing that you can't reach everybody the same way. So sorry, I went a little bit over. Had a little pause in the middle, so I tried to catch up, but I'm happy to take any questions. I don't know why the S is blue, but my email does start with an S, but I put my email there. Happy to take emails as well.
Great. All right, thank you so much, Shannon. That was great. Does anyone here have any questions? I'm gonna also pull up the Zoom chat.
I have a question for Shannon. Hi, Shannon.
Hi, Amanda.
So I was wondering, do you think, like, thinking from a treatment standpoint and adapting this to a clinic, probably in healthcare in general, adopting like a full assessment, like the one that you've developed, or giving that to everybody that we see is probably not going to be, viable in all healthcare settings. So do you think, I mean, obviously more work needs to be done to identify what are some of these profiles and what are the greatest areas of discrepancy in health beliefs, but do you like from a provider standpoint, is there a recommendation at this point for how to give that personalized, culturally humble care without having like necessarily the full benefit of a thorough health belief assessment?
Yeah, I mean, I think there's a lot out there just on training in culturally humble care. And most of it that I can boil it down in like a few seconds, is just the importance of asking about and considering personal values and preferences. And so, I think that the one of the challenges with that is when those personal values and preferences are inconsistent with what we know is best evidence. And being able to, this is where I think the term, the shift is moving towards culturally humble care instead of culturally competent, because it really reflects that, we need to step back, even when we are the experts in the evidence and the treatment of the condition. We are not the experts in the person, they are, and recognizing kind of that equalizing that kind of power differential a bit and giving equal weight to what the person is bringing to the table and their expertise and their own beliefs and their own experiences. So I don't know that that's a good answer. The hope is that this would be short enough. It could be included in like the, pre-visit questionnaires, and ideally, eventually that could spit out just the profile to a person. Obviously, that's not going to work so much in, every primary care setting or in community clinics that don't have the kind of EMR infrastructure. So we'll have to continue to be creative and think about ways we could make this more accessible in those ways. I don't know if that answered your question.
Okay, I see a couple hands up from the Zoom. I'm going to start with Dr. John White.
Thanks. Very, very interesting and important work, Shannon. I had a couple of methodological questions. One was, given that you were sort of very attentive to whether things would be understood similarly in English and Spanish, would there not be an argument for doing a factor analysis? I mean, obviously you'd need more subjects, but a separate factor analysis in the two groups to see if the factor structure is truly parallel. And my other question, and maybe this relates a little bit to Amanda's point about sort of the burden for healthcare, is I don't recall that you said anything yet about retest reliability. And it would seem that if we're going to do this as a pre-visit thing, it's going to want to tell us something about the person that lasts a pretty long time, as opposed to not this visit and then I'd need to do it again. So yeah, those are my two questions.
I'm going to answer your second one first. So that's absolutely important, especially because, the whole concept behind this is that it's a belief, right? And that beliefs are pretty hard to change. I'm not saying they would never change, but this should be a pretty stable thing. So doing the retest reliability is absolutely a critical next step psychometrically. We have to do, really ideally, we'd be able to do some kind of confirmatory analysis in the general population also, but you can also do that in specific populations. And actually, and I won't go down that rabbit hole, but there's a lot of kind of different ways, and I've done more rather than like confirmatory factor analysis using rash analysis because there's aspects of rash that actually let you examine the factor structure too.
Like differential item functioning stuff for.
Well, that gets even cooler, but that you need even more people. But yes, like that, there's a little bit of a PCA that's run as part of the rash.
Okay.
And in past, it's actually another way too to even reduce items a bit more. And so then making it shorter, which always makes it more accessible. So that's kind of the plan for the next step. And the test retest is absolutely critical. This one, because it was anonymous, we couldn't do that because we couldn't reach back out with some funding. Very different story, but this was really kind of tacked on. I will say one of the study that we have added this now to, I'm collecting these data, and I do have about 71 people so far. We're doing an intervention for dementia care partners, and we're collecting it in the context of that study. And one of the things we're going to explore, so the psychometrics so far in that population are comparable, which is encouraging. And we're going to explore whether different health perceptions are and different subscales on this measure are associated with treatment response and engagement. And we have engagement measures. We're doing the PRPS at all of our sessions. So we'll be able to look at our health perceptions correlated with level of engagement. So that gets to, are people even kind of participating actively in the intervention? So that's another direction on the research side that I'm really hoping to go with this. Back to your first point, yes, it would be really great to look at it in English and Spanish speakers separately, although I do feel confident putting them together because we did so much work to ensure at least equivalence of the items. I did run the factor analysis in both separately, which in the English is fine and largely, and of course was the same because I was driving it. The Spanish, we just didn't have enough people for it to really hold up, but I did run, one thing we could do is run the Cronbach's alphas, and because those are really essentially just correlation coefficients. And they were really good in the Spanish speakers. There was one subscale where one of them was like a 0.68, I think. That was the social and emotional health beliefs. And across the board, that was the subscale that was the most, even the name, like we had a hard time kind of figuring out what is the latent construct there. So I think that one might need a little more, with a larger sample. Rash analysis might help us there too, just kind of figuring out what's going on and are there any items on this that are making it messier. So that one in our Spanish speakers fell below the 0.7, probably because of the sample size and just the wider range there, perhaps the more looseness of that construct. But that would be a hope moving forward that we would be able to do that. And, again, I think if we had some funds to throw a little bit more resources, it would have been easier to target Spanish speakers. Our bilingual speakers who prefer to communicate in English now, which is a lot of the people we work with, took it in English. We asked them to take it in the language that they prefer to communicate with their healthcare providers in. So if they're bilingual, they may be communicating in English in their healthcare settings. And now I kind of wish we'd asked them to take it in both. Hindsight, right? As always. But that's another direction we want to go.
Thanks.
So I see another hand up by Namrata Rampurohit.
Yeah, hi, can you guys hear me?
Mm-hmm.
Great. Hi, Shannon. This is Namrata Rampurohit. I've heard you speak at ACRM multiple times, and always fun to hear your talks. So I really enjoyed this. So my questions are related to psychometrics and just understanding scale development. So my first question is, did you randomize the order of the items when you administered to the general population? And if not, how did you take into account the ordering of the items when you did factor analysis? And then my second question is, after you did the factor analysis, did you feel the urge to go back and change your conceptual model, or at that point, you don't touch your conceptual model? I'm just trying to understand.
Yeah, those
Thank
are good questions. So we didn't randomize the order in the sense that different participants got them in a different order, but we did not have them, like, we didn't cluster items together that we thought would factor together. So they were intermixed. The exception being that there were, the questions at the end, that every single one of them had the header, like there was the additional instructions that said, because of your, race, ethnicity, age, language, gender, sexual orientation, disability status, like I forget everything we listed. Because of those things, do you? And so then those, and all of those really ended up on the anticipated discrimination. So that, and those we really couldn't randomize without having to repeat those instructions every time, which gets really cumbersome. So I didn't do anything in the factor analysis to account for that because everything else was interspersed. It is something now when we go to it's another reason that from a kind of confirmatory standpoint, I'm leaning more towards rationalysis than towards just doing like a confirmatory factor analysis. Because of that, but some of that we can still decide. Sarah, now I've forgotten if there was a second part of your question.
Yeah, I had a second question about your the factor structure that you've developed now. Was there a reason you wanted to go back and then change your model, or at that point you don't touch your model? So I'm just trying to find out.
We did not go back and change the conceptual model, just because, or at least so far, because really the reason we put that together and published it was that was just the conceptual model that guided our initial item development, which was important. The factor structure ended up being pretty consistent with the model, and that's actually something that we need to, so we haven't published the factor analysis paper. It's close to submission, but that's one of the things we're kind of working through now in the discussion is how do the factor structure map onto our conceptual model, and do we need to change the conceptual model? I'm leaning towards no, only because we're not really proposing a theoretical model. And I know that's a kind of semantic difference, but I think it's an important one. The model was really to guide the measure, not to be a theoretical model of health beliefs universally, because there's a lot we probably didn't take into account. We really just pulled the concepts for a conceptual model from the literature where there was established links between the belief and a health outcome.
Thank you.
All right, Shannon, I think that's, unless there are any burning questions. I have one, but we are out of time and I think people have to leave, so I'll ask you offline if you don't mind.
It's okay.
But thank you so much for joining us today. It was a great pleasure having you, and super interesting and relevant talk to people studying TBI or really anything else. So thank you so much.
I'm very happy to. This is the first time I've gotten to present this, actually. So thank you for giving me the opportunity.
And we are so privileged to have the debut. So thank you. All right, take care. Bye-bye.